Hello all. Now we'll continue with my session on implementing diagnostic stewardship. The lab information system data and the clinical decision support system are important interventions to support improved test utilization in diagnostic stewardship program. Laboratorians should leverage the LIS data to identify the variations in utilization, to compare the providers, specialties, and institutions, and outliers should be further evaluated. Literature review should be done to identify the recommendations and guidelines that can be used to benchmark trends and can be very compelling. Clinical decision support and configuration of the computerized physician order entry is the most crucial consideration before bringing on a new test to promote appropriate utilization. Special consideration should be given to how the test is named and what information accompanies the orderable in the system. Often we see that the patient sample is sent, but the information is too late to help the laboratorians. So special consideration should be given to how the test is named and for the information that it accompanies. So that was about the LIS data and the clinical decision support interventions to promote improved test utilization in diagnostic stewardship program. Now let's see the importance of laboratory requirements for the specimen acceptability in the pre-analytical phase. Pre-analytical considerations are very important when implementing new technology and the prospective maintenance of test utilization. Failure to address these prerequisites for sample acceptability may lead to optimal utilization, directing the overall cost benefit of the diagnostic technology, potentially limiting its availability in the future. Implementing a minimal acceptability criteria for specimens that includes lab values. For example, for CSF examination, we can have a cutoff for proteins and glucose and WBCs for CSF examination. Or similar parameters like patient immune status and seasonality of disease may help to prevent test overuse and guide results interpretation. Failure to screen the specimens for quality prior to culture, for example, sputum samples prior to culture or urine sample prior to culture or PCR can lead to the inappropriate interpretation of results and excess antimicrobial use directed towards commensal flora. So the specimen needs to be screened for culture before culture or PCR to have rational antimicrobial usage as well as the diagnostic test. Then these are the implementations for the success and sustainability of the program. There's the importance of local context herein. The best practices alerts and the educational interventions may modestly impact prescribing practices. So they have also been associated with information overload. As a result, they may serve as barriers to clinicians' workflow, directing their potential positive impact. So such overload of information should be rationalized, and clinical settings are heterogeneous, and that how clinicians and laboratorians respond to the interventions will differ based on various factors. Factors such as clinical preference, local epidemiology, and availability of the laboratory resources drive the clinical process variability and result reporting. Individual clinical confidence in decision making, familiarity with the diagnostic test, department, and the level of education clinician receive about a test impact the way a clinician interprets the test. Now let's come to the learning curves and the temporary changes in the effect of program. Evaluating the effects of the diagnostic test may be variable due to the increased familiarity of clinicians with the test over time, particularly with the complex test, impacting the downstream actions based on test results. There is often a learning curve that can improve the performance of the diagnostic intervention over time. As the initial impact of an intervention may be low during an initial learning period, formal lead or run-in periods should be considered. Variations leading to learning and diagnostic efficiency improvement over time may be variable across settings. Careful consideration of any changes in the standard of care or the available treatment should be made with regard to measuring diagnostic efforts. Newer therapeutics compared to the past standards of care therapies may lead to changes in the diagnostic effects when introduced. So rapid diagnostics may also allow for rapid targeted therapy that can lead to improved clinical outcomes. So the combination of the better therapies with more rapid administration has the potential to yield an effect change that could occur over time and should be considered when evaluating the impact of advanced technologies with newly introduced therapies. So let us summarize with the charts given on the slide, which depicts about the future of successful stewardship, where there is a dissemination and intervention science and laboratory collaboration concept. We see the interventions from the organization perspective to it includes the perspective from leaders, management, and staff, while the patient perspective includes the turnaround time or length of stay, diagnosis, and quality of the test. So what is interventions? How the characteristics in the recipients in terms of organization patients? It is in terms of patient, it is a complexity, the unit, age, and condition. It is also influenced by the external environment such as academic agencies and guidelines. So in all these, the interventions and the recipient characteristics affect the adoption, implementation, and maintenance of the DST program. If it's, what do you mean by adoption? It is characteristics of the included or excluded staff or settings or the measures of the participation or acceptance of the interventions or compliance. That is adaptation. The implementation after adaptation, the measures of compliance, adherence, cost adaptations made during the interventions constitute the implementation. And the maintenance is how is the program still going more than 6 months after implementation? What are the measures or discussion of the elements of this program interventions in the program? So if this adoption, implementation, and maintenance in turn leads to reach and effectiveness, that is the percentage of individuals who participates or the quality assessment of who is aware or involved in the interventions, measures of the primary outcome, measures of the broader outcomes, measures of the robustness across the groups, measures of the short-term attrition, and differential rates of the patient characteristics or treatment conditions. So that was about the summary of this feature of the successful stewardship. To summarize, diagnostic stewardship is an essential interdisciplinary endeavor to improve diagnostic effectiveness and patient care. Modification can be made at the pre-analytical and post-analytical periods to improve the effectiveness of a diagnostic through interdisciplinary collaborations. Diagnostic effectiveness can be impacted by changes over time, including the learning curves on using the diagnostic and reduction of novel therapies that improve the results impact on clinical outcomes. Clinical relevance remains the driving force during the diagnostic evaluation, and that we never forget that good microbiology is clinical relevant microbiology. I'm thankful for the references used in this presentation for your kind attention. Thank you.